Next up, we have Dr. Patricia Musolino, who will be providing an overview of the Nexus trial.
It is a pleasure to be here. I'm really going to ask someone to bring Florian back into the room because he has to skip this presentation every single time I do it. Hey, Florian. There you go. Thank you. So I wanted to have him in the room this time. And this is, as you guys may or may not know, I've been working in ALD for more than 15 years. I think the first time was Florian. I was not even at MGH. And after interviews, says, "Didn't you want to write a chapter about microglia and leukodystrophies?" And that's how I got hooked up to the disease biology. And then as soon as I started seeing the patients, it was something that I couldn't ever walk away from. And I remember meeting a mom telling me how she was touring the country because her son has succumbed to an adrenal crisis. And you guys know this, mom. You know what happened after that. And I think is what we are most compelled about right now is we are having patients, boys and girls, diagnosed with ALD. It's a real disease. It has different phenotypes. And basically, the unmet need cannot be larger, guys. We are hearing about amazing things happening with an FDA-approved drug that can be accessed for certain patients in the US. But there's so much more that we really need to do. So a shout out for everybody to try to engage anyone that you know that could help us in the research, in the clinic, and in the drug development. I wear a very different hat most of the time. I'm the director of pediatric stroke and critical care. So I do work on vascular leukodystrophies, and it warms my heart to see the room and what ALD has gone to create, ALD Connect and the entire community. My other diseases, there are 50 patients in the world, 13 patients in the world, 80 patients in the world. So they're really working really hard to create their own space. I think we've been through this at times during the day, but we've been talking about complications. I just wanted to quickly go over the fact that we know, and I'm going to refer here to boys. So are born with a lack of the ABCD1 function. This is in the chromosome X. It leads to that paroxysm, not able to have that protein that then leads to accumulation of very long chain fatty acids, which we use for diagnosis in newborn screening and in the blood. And some of these boys will go on to develop an inflammatory form of cerebral demyelination, so attack to the myelin by the immune system. That usually is the time in life that most commonly occurs, 4 to 9 years of age. And these lesions in the brain, what you're looking below is the brain MRIs, sections kind of this way. And the back white spots that you are familiar with are the first signs of the lesion. We know that contrast enhancement, I love that some of the people I've been talking to are requesting their MRIs when they appear to have a lesion with contrast enhancement because my son, my brother, my husband has ALD. And we know that if that happens, that's the disruption of that barrier that never should let the gadolinium that you put in the vein leak into the brain. And that's when the disease really accelerates. And if untreated, unfortunately, we know that these lesions continue to progress like a wildfire. And even if we stop them, and what you're looking up there is more or less a loss of 15, just to give you a sense of what that number, we talked about loss, less score. That's what 15 will look like. The first one that has a patch like this one, let me see if I can get the mouse. This one over here will be a loss of 3 and 2, that's maybe 3. And that's a 15. These patients, even if we stop it right there, will start or continue to lose neurological function. We know the disease behaves that way because we don't reverse what is damaged. So that's a window for treatment. And we have, thanks to Hugo Moser and Patrick Avro, many, many years ago, more than 35 years ago, they did a compassionate use bone marrow transplant. And that's how we know that bone marrow transplant can arrest disease progression, even when it's at the fastest progressive rate, which is within that blood-brain barrier when disrupted. As you can see, there is a little bit of the red still in my timeline this year because it takes time. And you saw Troy showing biomarkers, and everybody knows that to arrest, to stop the disease from progressing and damaging the brain, we do have a period of time. It's usually anywhere from 6 to 9 months, some patients even 12 months, to stop the lesions from growing. And this is a schematic that Florian did many years ago to show and conceptualize the what I've been studying the most, which is that these immune cells that are coming from the blood come and start interacting with immune cells of the brain that become active and start eating up this thing in blue, which is the myelin, which is what ensheets the axons. And I just stop here. When we talk about cerebral ALD, we are referring to that attack, the immune attack. We're not talking about the degeneration of the neurons themselves, which is AMN. And that's the only thing I'm going to mention about that. Is another way of thinking. What does this blood-brain barrier disruption means? And here you have, as you imagine, a vessel with white blood cells and red blood cells going through. And this is kind of like if you were not to have this deficiency in the gene, the barrier, I call it the customs guys, the endothelium will not let the immune cells cross. That's called the blood-brain barrier. In reality, it's a much more complex unit with pericytes and astrocytes, which control that tightness and who comes in and out. And of course, there is inside the brain, the immune system of the brain, the microglia, that would also control and communicate with the immune cells of the bone marrow, which are circulating over in the blood. When you lose ABCD1, a very easy way to think about it, the endothelium becomes sticky and leaky. Sticky starts interacting more with immune cells than it should, and leaky because it opens up those tight junctions that should be very tight, and it starts letting immune cells come into the brain. And a lot of the research has been trying to understand what pathways are altered and can we intervene in those pathways. So Nexus is the Leriglitazone study for boys with cerebral ALD. And it basically, it's trying to go to the unmet need that we still have. I think if we put all together the patients that are able to receive transplant and the patients that are able to receive gene therapy, we're still not serving more than half of the boys. And if you talk to the part of the world I come from, 0 of them. So there's one, and we have Veronica here in the room, who is from another foundation in Latin America. There is the first patient with a good outcome transplanted in Argentina just now, and it was a subject in Leriglitazone trial, so I can tell you, we know this patient very well. There's a lot of unmet need. Transplant is not even a possibility for a lot of people around the world. And that has to do not with ALD, it has to do with the healthcare system that they don't have. So I just want to say the unmet need is still there. And the idea is this PPR gamma agonist, leriglitazone, is hopefully neuroprotective. It's also brain penetrant. It's not like pioglitazone, which doesn't necessarily cross, or the dose that you need to get there is very toxic. And that was the rationale of the study. Who were enrolled? Boys 2 to 12 years of age. And we did go a long way. So we took the population number 2. Those are the classic, it's the same patients population that we enroll in the gene therapy trial. They have a lesion, they have contrast enhancement. Population number 1 was the one that we did not know as much, which is the patients that have the tiny lesions, yet no evidence of contrast enhancement. And this is to the question that was asked here a little bit earlier, was can we push it early, even early than blood-brain barrier disruption? And that's because we know the sequence is followed in most of the patients. There is a lesion, and around 6 to 12 months later, there is contrast enhancement in that lesion. I'm going to humble all of this with the fact that we are basing this on 12, 17 boys that have been studied with the small, teeny tiny lesions. We publish everything we can, guys. This is still anecdotal data. So we are learning with the patients in the study. So not that we know the early lesions of the disease behavior. And I will make that very clear. So what was done in this study? Patients will be screened, and if they were not having a major functional disability, MFD, and they were having an NFS, that neurological score that was low, 0 or 1, and they have not received bone marrow transplant, they could start taking the oral drug. It's a drug that is dosed once daily, and they will get the first MRI at 12 weeks. That's 3 months, and then 6 months, and then 9 months, and 12 months. And thereafter, if they're stable, they can be spaced every 6 months. And we had put a criteria for what we consider a lesion not to be growing, which was not significant growth on volumetrics. That was a difficult word, significant, by the way. But most importantly, that they haven't developed any major functional disability or progress in neurological function. And the criteria for bone marrow transplant was the same criteria that clinicians have been using all along, so we didn't change that. If a lesion had contrast and the contrast didn't improve and continue to be there, that patient was considered eligible for bone marrow transplant, and it could come out of the trial if the patient, the family, the transplant was available. So this is what we were able to enroll, and I'm only showing interim results. So we gotta stay tuned for 2 years, a year and a half from now, until we get the 2-year follow-up and really can say more about what is the long-term effects of this drug and in these patients. These are the characteristics of the patients. You can see that between those without contrast, and we use a GD, gadolinium negative, and gadolinium positive, the lesions were the same size, but very, very early lesions. And you can see that they were neurologically very stable, and that also the lesions were tiny in volume. So we use this Lowe's score. It's almost like throwing points to the anatomy where the lesion touches versus something very strictly objective, which is the size of the lesion. You just draw the lesion in every single slide, and then you get a volume, and that's what we do. I have this in the middle of I cannot see the slide with the microphone. So this, I want to start with the safety, just to say that there were no withdrawals from the study. It was tolerated better than even adults tolerate the drug. We know there are side effects on swelling, edema. Some of the kids had edema, 3 of them, weight gain in 1 of them, and most of these patients, of the 3, were transient edema, and then it resolves. So they have a very good tolerability to the drug. We have not had any changes on adrenal insufficiency management. It was something that we were watching. No cardiovascular, no hepatic events, and the risk profile looked very tolerable. This is the results of the study. So in terms of the lows, and I again will say you're looking at 6 months, 12 months, and then we basically, here we have 11 patients that were evaluable at the time that we cut the data. We're showing you everything we had at the time that we cut the data. So the intention, and this was a study that needed to be done, it was designed this way to determine if we could continue the study. And at 6 months, we have 11 patients that we could analyze their data. You can see the lowest scores were pretty flat, but these are very early lesions, and we know less score may not be able to show you any changes in those lesions, and you'll see it. I put here from the publication in the New England Journal from the gene therapy, what the lowest scores look like in that cohort, the initial cohort of gene therapy. So 11 patients evaluable. We have the 2 populations, the standard change from the baseline on the lowest score was 0.6 and 1.1. This is what we got up to the time of the interim analysis. And some patients underwent bone marrow transplant in the study. There are 5 of them. Of those 5 patients that end up in transplant, 2 patients underwent transplant prior to week 24. So they were not evaluable for the interim analysis. And that was because the families were, and the investigators considered that the lesions needed to go. But to determine if they were transplant eligible in the study, they needed to have contrast 1 time, be on the drug, and still have contrast. If they didn't make it to the 6 month, means that we didn't get that evaluation possible. And then 5 more patients discontinued the study and went to bone marrow transplant or gene therapy. And of those 5, only 3. So these 3 and these 2 make those 5 that we are talking about. Only 2 of them met the criteria of the protocol that we had. So of those 5 patients that went to transplant, only 2 were considered transplant eligible. The other ones were choices by the family and the patients. And I do acknowledge how difficult it is to be participating in a study when you have to wait for the next MRI 3 months later to know if you're still thinking about bone marrow transplant. It's a very difficult study, guys, for a family. So many families and many physicians have decided, we have a good donor, we're in an awesome center, let's go and get this, and then I can sleep at night. And I don't have to think about my MRI 3 months later and 3 months later and 3 months later. I want to acknowledge that, because for anyone thinking about trials ahead for cerebral ALD in boys, this is going to be something that we need to think about. It's a lot of pain to put families through the studies and the anxiety that causes having to wait for the next 3-month MRI. So this is where the results up to this point were. On the patients without gadolinium, we saw 4 patients without progression. I'll show you the curves. On the patients with gadolinium, that was less. Of the 6 patients, only 1 we consider that have kind of arrested the disease, meaning not significantly continue growing or change the contrast enhancement to a significant point of disappearance. And again, this is the number of patients in the 2 cohorts that had lesion deceleration. And I want to just highlight that every patient we analyze have lesions growing slower. And I think that's the message that I don't have any questions about. Can we slow down the lesions with leriglitazone? The answer is yes. Compared to any natural history study, most patients will have a benefit in terms of lesion growth. But this is the lesion growth in volumetrics. So I told you the less score doesn't really capture the early disease, and these are the volumetrics of each patient. And you can see that there are some patients that do not, and this is later, so it looked good at 6 months, but then it started to grow more rapidly. So Katie brought up in the previous conversation, we do have to wait to know what this drug is able to do or not. But I'm very grateful we have 23 patients on the study because we will be able to have those answers. And I think we'll learn many things about this. So I do want to put here of the patients that we have at MGH Cornell, and there's very few boys from the Amsterdam cohort considered into this graph that Eric Malak and I were able to process and analyze and did it in a very systematic way. Most of them are published. And this is the growth of a lesion, natural history, from 0 to 12 months, from 12 months to 24, from 24 to 36. And this is the lesion growth in the patients that we have on leriglitazone. And you can see that the dots become lesser and lesser and lesser as we go along because we don't have the study length being fast enough. I took now a little detour for images. So for those of you that are neurologists or transplant people and the patients that you guys have been following your MRIs yourself, this is what we published with Florian in 2019, the description of these very, very early lesions. And this is very necessary because with newborn screening, this is how patients are presenting. So it looks like there is nothing. If you really zoom in, you might wonder there is a dot. There's definitely a dot 6 months later, and 3 months after, that dot is growing. But we learn, and in this study followed by the Eric Malak study on volumetric analysis, that this is a very fast exponential growth. It's around 2.5-fold increase per month in these early stages of the lesions. This is not for the entire disease, just for early lesion. And this is from, again, the New England Journal on the gene therapy, and is a representative of treated versus untreated. Here, I just use the baseline of this first patient treated with gene therapy and a patient from our cohort that at 2 years and what a lesion would look like if it was untreated that started with this size. And I'm still saying this is early lesion, but you can guys see that it's very different than a dot in the splenium of the corpus callosum. This lesion has already established itself, is growing, is going through the forceps, is expanding through the white matter. So I think this chapter, we may know how they go. This one is still to be seen and understood. And I invite anyone that wants to take on research. These patients are now much more available. There are going to be large numbers of images that will need to be analyzed and also correlated with the study. This is one of our patients with gadolinium negative. I took one of the patients that we had the longest follow-up. That's how I did it, to show you a lesion that looked a lot like the one that I was showing you before as the beginning of the therapeutics. And this is baseline. And then we give the drug every day. And this is what the lesion looked like 48 weeks later. And this patient, without contrast enhancing, and is a 10-year-old that by the time that we're talking about this is 12. Most people will not transplant. The family requested a transplant and the investigator felt with the match they had, they could do it. And this patient ended up in transplant. It didn't count in our trial, it doesn't meet the criteria for bone marrow transplant, but I wanted to tell you what is the circumstances when you are in front of the families working with them and they are in a study. And whether this was the drug doing the effect, what we just couldn't believe is why are we doing the transplant on that boy? And is this the right thing to do or not? Population number 2, remember the ones with gadolinium. These are the comparable ones to bone marrow transplant and gene therapy. And here's another patient. And you can see the lesion growth in the first, like kind of 4 weeks is going fast. And then it's on drug. This is 3 months. The lesion starts to shrink. I'm not very surprised. This drug has an anti-inflammatory effect. And we know this lesion and this signal here is that edema also, and inflammation in the brain. So some of these contractions that we've seen with Leriglitazone are explained maybe by the mechanism. And this is at 6 months, this patient. This is a 5-year-old. And I still have to see a 5-year-old that has a contrast-enhancing lesion of this kind to really go this way. Usually they really rapidly grow. And here I put a natural history progression in volumetrics in red or pink. And this is in blue, the volumetrics of the lesion of this patient. And this is the deceleration. So basically how rapid the growth was between 0 and 4, et cetera, et cetera. And that's the deceleration of the lesion growth. This patient remains on drug, but because he still has a very faint enhancement, he could be a candidate for bone marrow transplant. He doesn't have a good donor. And he could be a candidate for gene therapy. And in fact, he is being watched by both. and that's, I think, the way we should do this, guys, that we should have the kid being able to receive the treatment when it's really indicated. But at this point, he seems to have a very good response. Another patient that has a lesion, and again, I'm showing these lesions of now the new era of cerebral ALD, little tiny line, a little bit more like a hyphen. And then you can see here, this is now like more establishing, spreading itself. And still, with what we've seen, this is 3 months. This is less than what we have been able to characterize for these lesions in natural history untreated. So if you wonder what's the contrast of this patient, it has a contrast enhancement that is very, very subtle. I just like to show all the pictures because people can think that maybe I'm selecting what I'm showing, but the contrast is going away or lowering intensity, but it's still there. And I just want to acknowledge that thing. We're seeing lesions that are halting on growth, but the sign of inflammation that we consider the disruption of the blood-brain barrier remains in some degree. And I think we're going to have to think, what do we do with this? So, because I think the lesions not growing still means this brain is not progressing on losing function or in losing an effect. The question is it clinically relevant to decelerate lesion progression? And the answer I can give is yes, because we know the lesion size correlates with neurological deficit, with losing neurological function. And this is a little, very, very small sample. Again, I want to scatter everything so everybody can see every data point. These are tiny cohorts. This is the MGH and internal cohort, and you can see our untreated natural history volumetrics. I did pick here 3 to 6 months. Why? Because in the first 3 months on bone marrow transplant, we don't have consistent MRIs from 0 to 3. On gene therapy, we did have a 30-day MRI, but that was difficult because it's the only study we have it. So I had to look for a time point where I have data points that were comparable across different treatments. And for Leriglitazone especially, we do know there is a time where we see the lesion growing, usually the first 3 months, and then the lesions start plateauing. So 3 to 6 was a good representation for us of what we were seeing. Again, very small amount of data points, but very promising if you ask me. This is looking like bone marrow transplant, like gene therapy. The lesions in terms of size are looking the same. Do we have any biomarkers that tell us we are in the right track? This is neurofilament light chain, and Troy Land just told you about is an excellent biomarker, but it's not a perfect biomarker. And we do see the guy in black is the same patient that the lesion started to grow, and it had to go on transplant. And this patient, his neurofilament light change went up as well. So still very nicely correlating with our lesions on MRI, which I think is important to compare, to mention. MMP9, much less understood as a biomarker. A lot in my field of stroke, we use it for blood-brain barrier disruption in plasma. A normal value is below 100. Here, they're not clinically certified essays, blah, blah, blah. So we're not going to be using this one, guys, for clinical care until we really validate this in other cohorts. But less than 100 will be normal. These patients all are showing some degree of dysfunction of the blood-brain barrier, at least indicated by this floating metal proteinase. And this is what Leriglitazone was able to accomplish, is kind of plateauing and normalizing that level. I did wanted to show this, which Troy, in fact, showed earlier, which is that this is days again, this is 1 year, and you can see that neurofilament light chain may or may not change initially, but in general, it takes a while to go down. And only at 1 year, you can see how he split it here because there's a lot of time in between. You saw the levels going down. Again, this is 6 months, and I wanted to do that because we really are going to have to look at 12 months to see where are we going with this neurofilament light chain. What I'm glad is that I'm not seeing it rising, which is what will be happening if the lesions were untreated. So I think, again, an evidence of treatment effect in an indirect way and in a humble way. The trial is designed to acquire the pictures the same way that we had done for our studies on blood-brain barrier with this sequence called perfusion, very simple sequence, not fancy, very feasible. Most centers, academics have the sequence in their scanners, not a standard of care everywhere else. So if you are an artery and a capillary bed, you will have to flow your blood until you get to the vein, and white, the white blood cells, in red, the red blood cells that become blue because they exchange their oxygen. And this sequence allows us to see how long it takes to course through these capillaries. And if you broke the barrier and started leaking, we do have a constant of permeability with this, which is one of the most sensitives. This is what it looks like in reality. You see the gadolinium contrast coming in and out of the brain. It's just flowing through it. And the brain regulates its flow by opening the faucet. I call this, you get a bigger flow. That's your heart pumping more. Or the most common mechanism, you grab your capillary bed, the artery and the vein, and you homogenize the flow. That's how you can extract the most oxygen possible. This is a work of a group in Denmark, working with a group in Boston many years ago, and they give rise to the software that we currently use. Why am I going here? Because we have newborn screening. And I will continue to say we need to validate biomarkers in plasma to this sequence that is more sensitive. You see the red dot, there is no lesion on T2. And this took 6 months to show you something. In fact, it took more than a year to show you contrast enhancement, while the permeability in this sequence was already very abnormal more than a year ahead. So we have earlier markers that something is not working correctly that could tell us who could be a candidate for one of these preventions, quote unquote, prevention studies. Can we capture patients a little bit earlier, guys? Putting boys that are born on a drug that we don't know if it can cause any type of side effects during development is not going to be our answer. It's going to be probably closer to this or a nice biomarker in plasma that it correlates with this starting very smoldering disease of that blood-brain barrier. So we look at this, and I split them in two colors, the ones without contrast, the one with contrast, and this is our most robust biomarker of microvascular function. If you go to the Nature Communication papers of this year, we put the data on bone marrow transplant at MGH and the gene therapy, and we see a beautiful correlation between these markers. This is what the two populations look like. This is the Leriglitazone treated lesions versus the natural history. So again, signature that we are normalizing some of these blood vessel immune brain communications could be by the anti-inflammatory effect or many other effects that we know the drug could have on endothelium and microglia and other parts. And then I do the same exercise for everything. I try to see how are we comparing, because I don't think the answer we're going to get is going to be you fix the disease. We're not looking for that, and we just been talking all day how complex the disease is and what other phenotypes we're going to have. So it's literally trying to see, are we doing reasonably well, meaning as good as the therapies that we have? And then if you do that, now we have a choice. And then you decide profile, patient, lesion, side effects, what it could be the best indication. I will say again, if you give me a treatment that makes these families not have to go to an MRI the next 3 months to see if the lesion is there or not, they probably will pick that, and I wouldn't judge them. But there is a lot of families that don't want chemotherapy, or there is a lot of patients, 90% of the patients in Latin America, that will never access a bone marrow transplant timely for ALD. By the time the transplant is done, the lesions are very advanced. This is a more detailed adverse events on our patients in the Leriglitazone trial up to now. And this is summary of the conclusions. The study met the continuation criteria. That's why this study was done at 6 months. Leriglitazone was a safe and well-tolerated drug for boys. And there is early evidence of disease stabilization, a lot more to be seen in the next 96 weeks of year 2. The last patient was enrolled in May. So count 2 years from May 2023, and that's when we are going to have all the data for all the boys that were treated in the Nexus trial. And here is what am I doing here in Houston? Talking about this. I presented, Florian said, Patty, talk about global efforts for ALD and ALD Connect. And this was 2016. They continue to be. I want to point to Veronica. She's in that. And I was, guys, going to put a picture of your whole family. But Eduardo and Veronica lead this foundation, which is Lautaro Te Necesita. Lautaro is sitting right next to them in Argentina. And they literally have become the hub for all leukodystrophies, not just ALD, for entire Latin America. We get our Mexican patients through her more rapidly than through Florian most of the time, just to give you a sense. And it's the language, guys. Like if you can, and Florian speaks Spanish, by the way, but if you can really communicate, it opens up a whole different world. And Veronica has been able to understand and work with clinicians in a way that becomes a team. And I want to mention that almost a third of the patients on the gene therapy trial come from Latin America. This is the one of the meetings that we went when they prepared in 2016, and Florian and I went down to Mar del Plata and were there for a similar family event, but of all the leukodystrophies. This was last week, and I can't believe she's here either after putting this event together just a week ago. And they are growing. The needs are incredible. But I don't think that they need things that we need to give them. We basically have been taking from them. Through this telemedicine, this is the screening of CALD boys in the first 18 months of the gene therapy trial with Florian, 2013. We were seeing 12 patients a year. Suddenly, we are having more than 100 to see and to judge their lesions to see if they could qualify. And you can see the concentrations of patients coming from Latin America. This is a lot of work. It's all pro bono. We do video for some of the families. I always want a caregiver in the room because when I speak, I don't know if that goes directly, gets lost, and there's someone that is taking care of the patient there that needs to be able to understand. And also a lot of the times what we talk about, shock kicks in and I don't know what else they understood of what I'm talking about. And a lot of the times, unfortunately, the majority of the times is we don't have any treatment options to discuss. There is not even indication for bone marrow transplant. But this is what happens as a collateral, which I think builds on the network of clinical trials. You start building local networks of providers, families, patients, clinicians, and they start being able to make their decisions. There is very long-chain fatty acid testing in Argentina. It's going to go away. Chamoles is being sold, Florian. So we're going to have an even higher unmet need. So Stefan and Moser were coming your way for very long-chain fatty acids. And this is only possible because of this classic ALD Connect type of environment. A company, Minorex, trying to develop a drug for ALD, little Nexus study, and a ton of clinicians and researchers and patients and families working together to make some understanding of all this suffering. So with that, I'm going to close it for some questions. I don't know if we have time.
Thank you, Dr. Musolino. All right, questions.
So I'm going to try again with my question, because you're talking about communication and how do we talk to each other. It's a different language. And I think maybe we can enlist parents, maybe we can enlist the people. I mean, I'm pretty psyched about this study going on, and assuming it keeps going as well as it's been going, maybe people could talk about how I feel now compared to how I felt then. And this is the kind of concrete information that, for example, in the US anyway, you're going to need this to argue to Medicare and Medicaid and the insurance companies, because you're not able to say necessarily that you're curing it. So once you get the drug approved, you need to, and then you better gear up for making a whole bunch of it, because I think they're going to want it, but it's just about when the inflammation goes down and your lesion gets smaller, your 7-year-old can actually go to school, you know, things like that.
It's an excellent point. We are collecting quality of life. This is what you're talking about. It's mandated by the regulatory agencies to present even when you're trying to get approval. So we get quality of life questionnaires for the patients. It's been done for the gene therapy beautifully, and what is the impact that this is doing in the lives of families. Absolutely, 100%. I think we also have to probably share what does it feel like to be in a trial. And I think you have a lot of people here that have experience with that. And that may also help others connect. And this is another thing. It's very different when you don't have anything to offer. And you said, I have a boy, has a lesion. We are not going to have a we are on list on transplant. I can tell you what's happening so you guys know. Most of the Latin American kids recruited in Nexus trial are going to Barcelona because they speak Spanish too. So, and we have amazing investigators. Angeles and her team are incredible guys. And then they're on the drug, and then we meet the criteria for bone marrow transplant for some of them, and they're on the drug, and they're on the drug, and we wait. And we started the process of trying to have a donor found. And Christy, Duncan here, Troy, they all been involved on this because we just loop them in to see if they can find us a donor somehow. I don't know how. In Argentina, in Peru, in Colombia, in Brazil. And even if they do find someone compatible and they give their protocols, still the healthcare system takes more than 8 months average. 8 months. So Angeles is handling this in Spain, like treating the kids and treating them, even though we know they should be going to a transplant. So again, I don't want to minimize the challenge. I want to applaud the courage of both the participants and companies that put the entire life on their own skin and everything they believe to try to make it happen. Like, it's not easy to execute a study, as you guys know.
Hey, Patty. Great to hear you present. And as you said, it just takes a village, and you brought the village together. And I honestly couldn't think of a better person to think through all this physiology and microvascular changes. It needed you with your expert eye to do this. So big credit to you there. So and as I ask these questions and think about this, it's in order to make the study stronger, because I do think we need options for the patients, but I also think we have to ask the hard questions, because if we don't do that, this is not going to get approved. And I think one of the hard questions for me is, yes, there is slowing of lesion progression, but as far as I can tell, compared to BMT or gene therapy, you're not seeing with the same clarity that contrast enhancement goes away. Okay.
Correct.
So you hit it, we know it goes away. It may flicker and recur later, but at 6 months it's gone after cell-based treatment. So I think what's harder because of that is to show that there's a real inflection or a change. And And I think, you putting these side by side is really important. The second problem, I think, is around the dropout towards transplant, right?
Yeah.
Is this introducing some bias that we need to account for?
Yes.
Because if these are the patients who would otherwise be progressing, then you have to somehow account for that, right? So anyhow, those are my two hard questions, but meant
No,
to be
absolutely.
supportive. Yes.
Absolutely. And they're both connected, as you just alluded. So contrast enhancement, because we're looking at 6 months and because we're not doing a cell therapy, we're not putting any kind of gene function back. And I'm very gene therapy person. So I would say we have to be reasonable to what we are asking the drug to show. And this goes connected to your second question of dropout. At 6 months, we are seeing contrast not on everyone. Remember, our trial goal is to make that 10% at resting at 2 years to be 40%. We're not saying 100% of the boys are going to halt the disease. And I'm glad to see gene therapy was able to show like more than 85% of the patients can halt the disease. So that's a high bar and it's great. And maybe we get there. But the truth is, we are going to have to wait. We only have 6 month data. You saw how many patients go beyond the 6 months. It's a very small number right now. The contrast is changing and it's changing in the right direction. The patients that are going to transplant, we are meeting, all investigators are having the same way that we did with gene therapy, meetings to review that case. And it's almost like, can we all agree that this has an indication for transplant? So those patients lesions are growing. The contrast looks angrier or as angry as it was. And we are all in agreement, these patients need to go. The dropout is a different issue with this. And I do say we have to find a model to account for it. 0 to 3 is what most of these patients had dropped. And we don't even have a chance to get our criteria goes from 2 scans on treatment. The first one is baseline. They're not treated. So you can count that one as you're seeing an effect of the treatment. The first one really with treatment effects is 3 months. If you did this to a lot of bone marrow transplant patients, you will fail them. You will have offered them another transplant. You know what I mean? Where there's like average contrast enhancement effacement is 90 days average. That means that half of the patients do not do that. Okay, so that 6 month contrast is still there, 9 month contrast is still there, and we know it. So I think the only thing I can offer for the contrast resolution, I don't know if the drug is going to stop it, but it's too soon to say. I do know the contrast is going in the right direction in more than half of the patients that we have in the study. And for the dropout, I invite anyone that can help us to really conceptualize this 0 to 3 months. And when the first 3 months comes in, and I don't blame it, if they have a donor. So one of the things that we've been doing with investigators is if there is a clear donor, they are capable of accessing gene therapy or bone marrow transplant, it might not be a great candidate for Nexus because the family will be just waiting to go and flip the coin. Having said that, we have the families that said, I don't want transplant. I don't want chemotherapy. You know them. So I think I welcome, help me with a model, man. I just don't know how to account for all of this with the teeny tiny numbers of patients that we're talking about. So you see me smiling because I think that having the problem is the best that we can have. It's really having to think really hard. Troy.
Unfortunately, we are more than a half hour behind schedule. So we have a few questions I know you guys want to ask. Patty, if it's okay with you, can they ask you some questions after your talk privately? Okay, excellent. Let's give a round of applause to Dr. Musolino. Thank you so much.